Thank you so much, Jörg, for the invitation. First of all, really, thanks for organizing this meeting here. Thanks for bringing us all together in this context and to discuss really how stakeholder involvement, stakeholder engagement, well, I guess we're going to come to the different terms later also in breakout discussions, is been best done in order to make this new tool, which we're all having in our hands now, the HTA regulation, such a success that we really benefit all of us, but eventually the patients, from these legislative requirements which we now have in front of us. So really, really great. And I also like, Walter, your initial statement about responsible leadership. So that's really quite a nice theme, which I think should really go throughout the discussions we are having here today. I'm going to give you a couple of thoughts with regard to the collaborative work or the contributions regulators can make in this context. And you will already recognize that I stayed away from one certain term here, because I think it's very important to flesh out quite nicely the HTA regulatory interface and how we can connect the dots here in order to make this really a successful environment. Rosa has been setting the scene quite nicely already with her clinical perspective. François came in with the patient perspective. So let me now build on this and just give a couple of introductory thoughts, which I cannot manage to do with a click. Yes, I can. Fantastic, I do. So with the introduction, we need just to set the baseline here that, of course, regulators and HTAs have, can I say, different perspectives. They look at different things, and that's also for good reasons. So we have the benefit-risk evaluation on the one hand, and we have the contextualization of value in the healthcare system eventually, which has been supported by the HTA work. But the hypothesis, the underlying hypothesis is really that if we are aligning in terms of the evidence that's needed for all our different decision-making, then that really should facilitate that these decisions are not just sequential, and I heard the term earlier, but they are really also building on each other and really leading to a good access pathway, if you will. So it is about the elements that's also demonstrated in the PICO. It's about the elements that are part of the post-licensing evidence generation. But it's really the underlying principle that all decisions need to be based on evidence. And therefore, we need to be able to discuss, plan, generate evidence that addresses the different questions coming from the different decision makers. And in Europe, as you know, we have been working since 2010 quite closely between the EMA and the European Network for HTA, UNETA. We had initially the joint action supporting this. We have then the current service contract working with UNETA 21. But what all of this, for me, is absolutely fascinating is that we have seen what started as a project, if you will, the coalition of the willing, and I frankly remember the very first discussion we had back in 2010 together, is now enshrined in law. Certain elements which we have just thought are just sensible, and we work together with stakeholders in creating them, are now part of a European regulation which is going to be implemented. And I think that's a big recognition of the importance and the value of such collaboration. Now, where in the regulation can you find this? And there's a couple of touch points here. You've seen this diagram already in Rosa's presentation, and I guess you will see this in all presentations these days, because that's basically the governance of the HTA regulation. And the addition I did just here was to indicate where are the touch points for engagement between regulators, so EMA concretely, and the HTA coordination group or its subgroups. And they are really going across the joint scientific consultation, the joint clinical assessment. They go into the development of methodologies, and of course, in the identification of emerging technologies. So all these different subgroups need to work together in a sense of we have touch points where we should engage. Very concretely, you find in the regulation these three areas here. The emerging technologies, the joint scientific consultation, also known as scientific advice, and the joint clinical assessment. Now, one very important remark here. When it says joint on this slide, it's not joint work between regulators and HTAs. Because sometimes I get that as a bit of confusion. So are you now doing a joint regulatory HTA clinical assessment? No, right? It is the joint clinical assessment done jointly by the HTA constituency under the coordination group. But in the context of joint clinical assessment, of course, the previous decision on benefit risk can inform, can provide insights, can provide explanations. How do you come to a certain label, a population being included into the labeling? All of this needs to be transferred. The knowledge needs to be transferred at the right point in time. And I heard also earlier Rosa talking about the parallel work that needs to be done. And I think that's a very important concept, which I think we need to work on a bit more also in the upcoming month or so to see how this practically works out. And equally, joint scientific consultation, so the scientific advice, it is joint amongst the HTAs. When regulators are involved, it is, and that's the beauty of all this terminology, the parallel joint scientific consultation. So that's when the regulators come in. But just really to clarify what's meant in here, because I think it's an important baseline. What's also important in this slide is what's on the bottom left corner. It's that there's, of course, a lot of transversal elements in the legislation. And one of them is for the decision makers, meaning regulators and HTA bodies, to be able to work in a confidential space. And we are saying this based on the project experience, where we had to work around, where we had to find ways of individual arrangements, etc. This should be all facilitated like we work with other decision makers in this area. Now, concretely, what are we doing? We are, of course, preparing for the implementation. We have our EMA United 21 work plan, which was mandated by the European Commission to help support the implementation work. You see here 9 topic areas which are part of this work plan. Just to single out very few, there's something about real-world evidence, just because I heard it before, and of course, which conference would be complete without mentioning this? So there is work ongoing. There's also work ongoing on how do we engage with patients and healthcare professionals, but also patient-relevant data. That's more the evidence that we have at hand. And then a topic which I find is really, really important is a concept of, well, regulators call it extrapolation, HTAs call it evidence transfer. I personally even prefer evidence transfer because it really says there is existing evidence you transfer it from because there's a scientific context behind. But we all need to have the same view on this and its application because, again, think about the sequence of decision making. If regulators were to agree on the feasibility of evidence transfer to be employed for a certain patient population, but subsequent decision makers say, no, actually, we would need clinical data for this, then we struggle in the decision-making chain, right? And that's why it's so important to come together very early on. But it's also important to look at it from the different clusters, if you will. And this is just one publication which came out very recently, which is based on a 3-dimensional review. First of all, a desk review of literature, of how the collaboration between regulators and HTA at the interface has evolved. The second one, by review of joint clinical assessments or joint RIAs under joint production from United Joint Action 3 and respective EPAs. And thirdly, and maybe most excitingly for me, interviews with people who are doing the actual work, so regulators and HTA authors doing the actual work, sharing their experience. And what this shows is that, of course, there is by now already a very good understanding also of the value of coming together in terms of joint scientific consultation. We are getting together when it comes to joint clinical assessment and contribution to it in terms of joint production, but I think there's work to be done. But there's a big gap still, and this is about pre-planning of post-licensing evidence generation. And I need to come back to what Rosa was also saying earlier. Sometimes, or maybe can I say often, The issue when it comes to early access decision making is also that there is uncertainty about the plan for post-licensing evidence early enough so that one really addresses early enough the known to be uncertainties in the data set, right? And this is really then a call for developers to come early in this engagement, to come early in this plan. It's not enough to look just for the initial decision making. You need to look beyond. And that's also something which comes out quite nicely in this review here. So let me conclude just in the interest of time, because otherwise the chair gets very nervous with me. I think the discussion is crucial along the decision-making chain around the evidence. It's absolutely crucial, and I hope I've given you a couple of examples. And the HTA regulation recognizes the value and gives us so many opportunities which we really need to use best. There is a lot which we can do around evidence methodologies. And again, this is pure technical work, but again, this is why a conference also like today is important, because it requires the various stakeholders. But let me finish just by one thought, and maybe that's also something we would like to pick up later. The regulation gives us a couple of frameworks, very concretely, of processes, etc. But of course, the engagement needs to go beyond. It cannot stop there. It's about communication. It's about research projects. It's about training. There's so many activities which need to be done to make this really a conducive environment. And ultimately, it's about making choices. And everybody needs to make choices. And that comes a bit back to your introduction also. Healthcare system ultimately needs to make choices. And whatever we can do along the decision-making chain to support these choices will in itself provide value. And with this, thank you.